Good afternoon, everyone. I'd like to welcome you all to our grand round. We're honored today to have Dr. Jennifer Lee presenting to us. Dr. Lee is a cornea specialist and the current director of the Cornea and External Disease Service at UC Davis, and the current chair of the Medical Advisory Board of the Eye Bank Association of America. She's a recipient of many awards, including the Townley Payton Award in recognition for her outstanding contribution to iBanking. She's an educator and a renowned researcher. I have personally enjoyed writing an editorial for Cornea with her, titled as The Future of Corneal Donation and Transplantation Insights from COVID-19. She's going to speak to us today about the processes of iBanking and corneal donation. The mic is yours, Dr.
Great. Thank you so much for having me today. Good afternoon, everyone. It's pretty early here in California still, but it's always good to get up early and get the day started. So today we are going to talk about a topic that is really near and dear to my heart, which is corneal donation. I do not have any financial interest, but I am the medical director at our local iBank Sierra Donor Services. So whenever I think about what we're doing today in the present time, I always like to think back to where we've started. And the history of corneal transplantation really starts with Franz Reisinger, who in 1824 was the first person to suggest that we could even replace an opacified human cornea with a transparent animal cornea. And he termed it keratoplasty. So legend has it that the first successful penetrating allograft was performed by Samuel Bigger in 1837, and it was on a gazelle. The story goes is that he was held captive by Bedouins in Egypt while traveling, and there was a pet gazelle that had lost one eye and was blind in the other from a corneal injury. And so he reports grafting a cornea from a wounded gazelle onto the pet gazelle with restoration of vision and a transparent cornea after about 10 days. There is some question as to the validity of his story, as he was really never able to replicate his results after that. But by 1905, Edward Zerm performed the first successful penetrating keratoplasty on a human. And this gentleman, Golgar, was the first corneal transplant recipient. Edward Zerm is a name that many of us who are performing corneal transplantations may know. But the real question is, do we know who the name of the first corneal donor is? You know, without the first donor, we would never had the first corneal transplant. So his name was actually Karl Brauer. And he was a 12-year-old boy who had suffered a traumatic injury to an eye. And using the von Hippel-Treifine deep anesthesia aseptic technique, Zerm was able to transplant his cornea onto Golgar, who had had bilateral alkali burns. And of the two transplants that were performed, one was able to survive for the rest of Golgar's life. And so began the story of corneal transplantation and corneal donation. And so things evolved actually very rapidly after Zerm's first surgery in 1905. By 1931, Filatov performed the first cadaveric corneal transplant on tissue that had been preserved for 24 hours. And by 1937, R. Townley Payton performed the first US corneal transplant. And by 1944, the first iBank was established in the US by Payton. R. Townley Payton helped establish the iBank for Sight Restoration in New York City in 1944. The idea was really to have a systematic plan to obtain, preserve, and distribute eye tissue. As corneal transplantation progressed, so too did iBanking. There was a proliferation of iBanks in the 1940s and 1950s, which ultimately led to the establishment of the Committee on iBanks by what was then the American Academy of Ophthalmology and Otolaryngology. And it started off consisting of 27 ophthalmologists and 11 iBanks. In 1961, the Eye Bank Association of America was officially founded. There were 10 iBanks at its initiation, but within a year, there were 35 member iBanks. So it really grew very rapidly. And I think it's important to note that from the very beginning of the organization, there was collaboration between physicians and iBankers from the very beginning. And so the EBAA was really the first iBank association of its kind. It's the first organization of its kind within organ or tissue transplantation. And it was the first group to establish things like medical standards, an accreditation process, technician certification. And really, it has paved the way for all sorts of organ, again, tissue donation organizations throughout the world. Currently, the Eye Bank Association of America consists of 92 member banks. 77 are in the US, and we have 15 international banks in 8 different countries. In 2019, we provided over 85,000 corneas for transplant. Of those, about 50,000 were placed in the US and 28,000 were placed internationally. Ultimately, the vision of the Eye Bank Association of America is the restoration of sight worldwide. So not just in the US, but really across the globe. So my hope for us today or in our time together is that I can give you an overview and an appreciation of the eye banking process and everything that's involved in providing a donor corneal tissue to our patients. So we'll go through some of the different steps of eye banking in the United States, from donation to transplantation. And while every country and every system may be a little bit different, I think that for the most part, the process is very similar. The first step, as you can well imagine, is notification of death of a donor. In the US, part of what allows us to have such a robust donation system is the fact that there are regulations in place that require that hospitals notify an eye bank or an organ bank of all hospital deaths. So if a person dies in a hospital, we are automatically notified. That being said, if a person dies in a coroner's office, a hospice, funeral home, or at home themselves, the process can still be initiated by any of those organizations or people. And then finally, in the US, there is also a donor registry where people can sign themselves up to be a donor. The donor registry essentially gives first person authorization for use of your organs, tissue, ocular tissue. People are able to register for themselves online. And then in the US, I think part of what makes this a very successful program is that anytime you renew your driver's license, you're given the opportunity to register to be a donor, and it actually shows up on your driver's license. The donor registry in the US has really been a great success. As of last year, over 165 million people had registered to be a donor, which is about 50% of the US population. So once the donor has been authorized for transplantation, the donor medical records are screened and the next of kin are interviewed to determine eligibility for donation. So essentially, whether or not this person is okay to be a donor. The screening process is actually quite extensive and it occurs via multiple different routes. First, the patient's medical information is obtained through the hospital, through the clinics. A thorough past medical history, social history is obtained from the next of kin or someone who knows the donor very well. And then finally, if there's any additional information that's needed, we follow up with the primary care physician or their healthcare providers for that patient. The donor screening criteria are based on multiple different standards, including the Eye Bank Association of America medical standards, FDA guidelines, CDC guidelines, and individual eye bank specific criteria. As you can see here, there are many things that can exclude a corneal donor, but the majority of which are things that relate to potential infectious etiologies and malignancies that can be transmitted. The FDA also has criteria that we're obligated to uphold. And again, their primary concern is communicable infectious diseases. And so we will screen for travel history, high-risk behavior, medical history for these things. Finally, once that initial screening is complete, the ocular tissue can then be recovered. The recovery typically occurs within 12 to 18 hours of death. It consists of an external physical exam of the donor, a pen light exam of the eyes, a prep using povidone iodine of the eyes, recovery using aseptic technique, and a blood draw that's required for serology tests. And so this is an example of what a recovery technician would be looking at during the recovery process. Again, the focus is really on any stigmata of high-risk behavior. For instance, track marks suggestive of IV drug use, homemade tattoos, and an ocular exam looking for any obvious abnormalities. Here you can see what a demonstration of the recovery process might look like. In the US, the vast majority of eye banks recover just the corneal scleral button, not the whole globe, unless otherwise requested. And these eye bank technicians are trained by medical directors at eye banks across the US. And so we are ensuring that they know sterile technique and that they have good technique in general, where they're not really adversely affecting that corneal tissue. The tissue is then placed in a preservation media, which in the US is done via cold storage with Optisol GS. Finally, blood is drawn for the required infectious disease testing, which includes HIV, hepatitis B and C, and syphilis. So once that tissue has been recovered, the next step is really evaluating the donor cornea to see if it meets the minimum quality requirements for donation. So again, we've already done the testing for the patient to see if the patient or the donor meets the necessary requirements, but now it's really a question of whether or not their cornea also meets the requirements. And so again, eye bank technicians are trained to evaluate the cornea. They look at the epithelium for edema, exposure, sloughing. They look at the corneal stroma for infiltrates, opacities, edema. They evaluate the decimes for folds, tears, stress lines. And finally, the endothelium is evaluated with specular microscopy to really look at the health of those endothelial cells. And there is a minimum cell density requirement of 2,000 cells. So once we have a tissue now that's both eligible from a donor side and suitable from a cornea side for transplantation, then we can start the process of processing that tissue based on the request of the surgeon. So as you know, in the US at least, tissue processing has really revolutionized eye banking and corneal transplantation over the past 10 to 15 years. Without these advances, the boom of endothelial keratoplasty would likely never have occurred as quickly and as profoundly as it did. This is a quick video showing an eye bank technician preparing a pre-cut DSEK tissue. They are using a microkeratome here, which slides across the corneal surface and pre-cuts that tissue to a specified depth. In this case, they're using a 350 micron depth keratome. And so you're going to get hopefully somewhere around 100 micron donor button at the end of the day. Again, our technicians are trained to do this. They're evaluated annually for their skills. And what you'll find about many of these eye bank technicians is that they have steadier hands than a lot of us. But this is somebody this is a tissue that's been processed for pre-cut DSEK. And really, this is a slide that's seen in a lot of presentations about corneal transplantation. And what it's showing is this very rapid increase in endothelial keratoplasty procedures over the past decade. You can see that in about 2010 is when the lines cross, where we are now doing more endothelial keratoplasty than penetrating keratoplasty, at least in the United States. And I would attribute a lot of this to the things that the eye bank is able to do on behalf of surgeons now. The other major form of tissue processing that occurs at our eye bank is now DMEK processing. This is a video of one of my technicians performing a DMEK procedure. And what you're seeing here is they are going to strip the patient's endothelium and decimes membrane off of the corneal scleral button. And again, you'll notice just the steadiness of his hands. It's very, very impressive, these eye bank technicians and the skills that they are able to acquire through careful training, obviously. The fact that the eye bank technician is able to do this for us in this day and age essentially saves me a significant amount of time in the operating room. And so when I receive a tissue for DMEK surgery now, it is pre-stripped, pre-stamped, pre-cut, pre-loaded. They've done basically everything for me besides inserting it into the eye. And again, it is a huge time saver in the operating room. And truthfully, I think they do a better job than surgeons can do because they're doing it all the time. And so here we see, again, just how quickly DMEC has taken off in the US over the past 5 years. By 2019, you can see DMEC's almost catching up to DSEC at this point in terms of the number of procedures that are performed in the US. So now that the tissue has been processed, it's time to distribute it. The maximum time that a tissue can be stored, cornea tissue can be stored, is 14 days in cold storage. And these tissues are distributed via a fair and equitable distribution system. And this takes into account emergencies taking the #1 priority, followed by local needs, national needs, and then finally international needs. But once the donor cornea has been transplanted, the work actually doesn't stop there. Eye banks still have to follow up with surgeons about any potential adverse reactions that have occurred related to the tissue, and they're required to follow up within 3 to 6 months. And then finally, eye banks do a lot of care to follow up donor families and to thank them for what their loved ones have given to us. Remembering the donor, this is the part that I think as surgeons, we often don't think about enough, and we don't remind our patients enough of the gift that they've received. And so this is something that I really try and emphasize with my patients, is this human side of donation, and again, what we were able to accomplish with the gift that we've been given. So there you go. That's a really quick overview of what eye banks do from start to finish, from death notification all the way through utilization and follow-up. And really, it's remarkable to think about, because all of this happens within 2 weeks, right? That's the time frame in which it has to happen. And often it happens in a much shorter period than that. And so again, the eye banks are doing so much of the heavy lifting for us as corneal surgeons that we really do need to appreciate all of that. So now that you have a better idea of the process that a tissue goes through to get from a donor to a surgeon, I want us to focus a little bit more about how we ensure the donor corneal tissue is safe. I would say that there are 3 primary means by which the EBAA tries to ensure the safety of donor tissue from eye banks. One is the EBAA medical standards. 2 is a robust adverse reaction reporting and monitoring system that's in place. And 3 is the eye bank accreditation process. So let's talk a little bit more about the EBA medical standards. The opening statement of the medical standards states the goal of the medical standards right from the very beginning, and that's to assure consistently acceptable levels of quality, proficiency, and ethics in dealing with ocular tissue for transplantation. And it helps to define the minimum standards of practice for all eye bank functions. The medical standards were initially developed and adopted in 1980. And it's hard to imagine a time before there were eye banking medical standards, but at the time it was sort of hotly debated. People were concerned whether or not eye banks would be eliminated if they couldn't comply with medical standards. They wondered whether or not it was really necessary to have medical standards. And again, in this day and age, it's hard to imagine a world in which we didn't have some sort of minimum criteria by which we were able to assess donor corneas. But again, these medical standards really ensure that there's a minimum quality that's met. So from an EBA accredited eye bank, if you get a tissue from one of our eye banks, you know that that tissue is suitable for transplantation. The medical standards are also not so strict in that they allow for variation and innovation by eye banks. And it is endorsed annually by the American Academy of Ophthalmology. The medical standards apply to any and all eye bank functions, so everything that we've already talked about, in addition to the day-to-day operations of an eye bank. It's important to note that the medical standards are independent of our FDA guidance and regulations. And this was done very deliberately. The medical standards are really meant to be evidence-based and not government mandates. The eye banks have to also comply with FDA requirements, but again, the medical standards from the EBA are standalone from the FDA requirements. Um, and ultimately, it is up to the medical advisory board of the EBAA to establish these medical standards. The medical advisory board consists of both physicians and eye bankers, and so they work together to create the medical standards. Um, One of the things I think it's most important to remember about the medical standards is the fact that it is a living document. They are constantly being updated at least twice a year, more as needed. Um, and additional changes and revisions are based on things like new serological testing, such as nucleic acid testing that was developed, new eye bank processes like DMEC or DSEC. Those are now all regulated within our medical standards. New public health threats, and adverse reactions. And so, for instance, in the past, things that we've dealt with include hepatitis, HIV, West Nile virus, and even in the past 10 years that I've been involved with the Medical Advisory Board, we've had to address the Ebola outbreak, Zika virus, a report of malignant melanoma being transmitted from a donor to a recipient, and of course, COVID-19. But we'll talk a little bit more about COVID-19 in a little bit. And so if the medical standards are one way for us to help ensure the safety of donor corneal tissue, the second way is through close monitoring of any adverse reactions. The EBA has an online adverse reaction reporting system called ORS. And ORS was developed initially in the 1990s in order to help track adverse reactions. The online system's now been in place since 2004. Again, eye banks are required to seek any postoperative outcome from surgeons between 3 to 6 months after surgery. And the goal there is really for us to catch any of these adverse reactions, whether it's a regraft, a graft failure, an infection. And the medical advisory board actually reviews all of these adverse events and monitors for any trends. And what this allows for us is to really understand the efficacy of the medical standards that are in place and to help prevent any future adverse reactions. Reportable adverse reactions include things that are possibly, probably, definitely transmitted via the donor tissue. And they include infections such as endophthalmitis, keratitis, or any sort of systemic disease, or biological dysfunction. So again, primary graft failure that the cornea never clears after the first 8 weeks, an early regraft in the case of DSEC or DMEC, where the donor never sticks, any sort of transmission of a donor corneal dystrophy from donor to recipient, any issues with malignancy or prior refractive surgery. If an adverse reaction does occur, eye banks are required to report this to the EBA within 30 days. And so what that means is that practically, we're able to review all of this data through our online reporting system, and again, look for trends. So for instance, concerns with trends and early regrafting with endothelial keratoplasty procedures. This is something that we've looked into over the last few years. And then concern for an increase in endothelial keratoplasty fungal infections. This has been a really hot topic as well for the last several years within the eye banking community. And we know this is happening because of our ORS data system. The fact is that because everything's reported, we're able to monitor, and then we're able to address these concerns. The final step, I think, in ensuring the safety of corneal tissue is our eye bank accreditation process. The EBAA is the national accrediting body for all eye banks in the United States. And the accreditation process is based on our medical standards. Eye banks are required to be inspected at least once every 3 years. And the accreditation process, the inspection process, really meets or exceeds any of our state or national regulations. And so ultimately, with the medical standards as our backbone, the accreditation process really ensures that eye banks are following our medical standards. We're able to have a very large network of safe and accessible corneal tissue for surgeons and patients. You know, I know that if my eye bank doesn't have a corneal tissue available for me for my surgery this week, and they have to import a tissue from another eye bank, I know that if that eye bank is accredited, I can trust that tissue to be safe for my patients. And so finally, I kind of want to talk about, of course, the hot topic of the hour, which is eye banking in the time of COVID. Um, Now that you've kind of heard the whole process that we go through in order to obtain a corneal tissue, and the process in which the EBAA goes through to address public health threats, um, let's talk about exactly the process we've been going through to think about COVID-19 and ensuring that our donor pool remains safe and healthy during this period. You know, it's hard for me to believe that it's just been a little over a year since we started talking and hearing about this new disease coming out of Wuhan, China. The global impact has obviously been incredibly profound. We were just talking, it's not quite over yet. We don't really know where it's heading, but both in the US and across the world, those numbers are creeping back up again, despite vaccination. And, you know, vaccination feels like it is giving us a little bit of hope, at least. But there's issues with vaccination as well. And I think one of the big issues that we have is, of course, the problem of worldwide disparity in terms of access to COVID vaccination. And so as a global community, I think we have still a long way to go in this fight against COVID-19. In the past year, though, I think we've all learned a lot more about coronaviruses than we've ever expected to know. As we're all aware now, COVID-19 does have ocular involvement. Numerous studies have shown that SARS-CoV-2 can be associated with a follicular conjunctivitis, and up to 30% of patients may develop some form of an ocular manifestation. But in general, it seems that these patients have a normal visual acuity without corneal lesions, pseudomembranes, or anterior chamber inflammation. The rate of positive SARS-CoV-2 PCR from conjunctival samples really ranges in the literature from anywhere from 0 to about 7%. In most cases, in most instances, these positive conjunctival swabs for SARS-CoV-2 were seen in patients who have conjunctival symptoms, although not all patients who had conjunctival symptoms had detectable virus in their tears. Additionally, there was one reported case of an ocular swab that was positive for infectious virus. The onset of ocular symptoms is also very highly variable. In some cases, ocular symptoms can be the presenting sign of COVID-19, while in other cases, it seems to develop as a later sign in patients with more severe disease. But SARS-CoV-2 RNA has been detectable in conjunctival swabs out to as late as 27 days after initial symptom onset. Recently, there have also been multiple case reports on intraocular involvement of SARS-CoV-2, including vitritis, panuveitis, optic neuritis, retinitis, and lesions that involve both the inner and outer retinal layers. So in light of what we know about COVID-19 and how it can affect the eye, I think the question is, what is the implication on donor corneal tissue? And obviously, this is something that we would all very much like to know. At this point in time, multiple studies have demonstrated the expression of receptors that are able to bind to the viral spike protein of SARS-CoV-2 on the ocular surface and allow for viral entry into the surface of the conjunctiva, the limbus, and the cornea. However, Minor et al. Out of WashU, they looked to see whether or not SARS-CoV-2 could actually replicate in human corneal tissue. And they were unable to detect replication of SARS-CoV-2 in human corneal donor tissue. And so what this suggests is that even though there are these receptors in place that would allow viral entry into the tissue, there is still a question of whether or not the virus is able to still replicate once it's attached itself to the donor, to our ocular tissue. In terms of the presence of SARS-CoV-2 in human corneal tissue as well, the results are actually very mixed. One of the earlier studies by Bayud looked at 10 whole ocular globes recovered from patients who had passed away from COVID-19. And they actually found no viral RNA detectable in the ocular tissue or the intraocular fluid. However, since then, there have been several studies that suggest otherwise. In this study by Casagrade, they were able to detect SARS-CoV-2 in postmortem corneal tissue, in 55% actually of their corneas, which is quite a lot. However, they actually questioned whether or not this was true infection versus contamination of the cornea through blood and aqueous. In a more recent publication by Sawant et al., they looked at several different categories of potential corneal donors. They looked at 33 ocular donors that were ruled out unrelated to COVID-19. However, they tested all of these donors after postmortem, and they found that there were two categories of patients. There were patients who were positive for COVID-19 on a postmortem swab who did not have symptoms prior to death. And then they had another group of patients who had all the symptoms of COVID-19, but who did not test positive on a postmortem PCR test. And what they found is that about 13% of their scleral and corneal tissue samples from those patients tested positive. And so this is concerning, of course, because these are the patients who either are asymptomatic COVID-19 carriers and who otherwise wouldn't be screened out by our EBA medical standard criteria, or they're symptomatic patients who had otherwise tested negative for SARS-CoV-2. They then looked at a group of research donors who actually died from COVID-19. And the rate of positivity of samples was even higher in this group. And they found that 6 of 10 donors tested positive on a conjunctival anterior corneal or posterior corneal sample. And what's interesting is that 3 out of 20 of their vitreous swabs tested positive as well, suggesting again that there's infiltration via the retinal vasculature of the ocular tissue with SARS-CoV-2. So there's still a lot that we don't know about how SARS-CoV-2 impacts corneal donor tissue and transplantation. But fortunately, in the literature, there are still no reported cases of SARS-CoV-2, SARS, MERS, or any other coronavirus transmission via transplantation of ocular tissue. Per the FDA, respiratory viruses in general are not noted to be transmissible via transplantation of human cell tissue or ocular tissue. In the US, we do know of 8 reported instances in which corneal tissue from infected donors was inadvertently transplanted. In each of these cases, the post-mortem testing was performed by a tissue recovery agency unbeknownst to the eye bank. And so the eye bank received the results after the corneal tissue had already been transplanted. Fortunately, to date, the graft outcomes have been successful in all 8 cases, and none of the recipients are known to have developed COVID-19 during the early post-operative period. So again, as of now, we still don't have any actual cases of corneal tissue causing a SARS-CoV-2 infection. In spite of this, obviously, the Medical Advisory Board of the EBA has been monitoring the situation very, very closely. There is a subcommittee, the Policy and Position Review Subcommittee, that's been tasked with creating our policy regarding COVID-19. And this group contains both, again, physician and eye bankers. The first recommendations were sent out at the beginning of February. To say the least, our EBA guidance and screening recommendations have really been a constantly evolving document. As we've learned more about the disease, as we've learned more about this pandemic that's spreading across the country and across the globe, we've had to adjust our screening recommendations based on the changing nature of the pandemic. For instance, early on, the criteria were extraordinarily conservative and included a lot of travel screening recommendations. But as it became a global pandemic, obviously, and a national issue in the US, the travel screening criteria went away. And as we started opening things up, we've had to adjust our criteria to be less stringent to allow for continuation of elective corneal transplantation surgery while still really ensuring the safety of that donor tissue. The most recent update was actually in October. We have not had another update since that time. This is a summary of our current COVID-19 screening guidelines. It can be found on the EBA website at restoresite.org. This is obviously a very busy slide here. But so we'll look at a little more closely at each different section. We've laid it all out in kind of a table format to make our recommendations as clear as possible for both eye banks and the medical directors who are reviewing the corneal tissue. In the first category, obviously, are patients who have tested positive for COVID-19. If they've tested positive within the past 28 days, they are not eligible for corneal transplantation. However, if they've tested negative in either a post-mortem swab or a recent pre-mortem PCR test, they may be eligible. And this depends on whether or not they have signs and symptoms consistent with COVID-19, whether or not they have another etiology to explain whatever symptoms they have, like COPD or something like that, whether or not they have any close contacts with a known COVID-19. And then all of these variables are taken into consideration and eligibility is determined based on them. The recommendations in terms of signs and symptoms we've created them based on recommendations from our CDC. And so the signs that we think are most consistent with potential COVID-19 infection include ARDS, pneumonia, or a CT showing ground glass appearance. And symptoms include any of these following: fever, cough, shortness of breath, loss of taste or smell, or any of these more less sort of specific findings. And again, the problem with COVID-19 is that the symptoms of COVID-19 and even the signs of COVID-19 are incredibly non-specific. And so there are many, many other diseases that a patient may die from that are not COVID-19 that will fall into these categories. And so unfortunately, we are probably losing some donors to this. Close contacts, again, is our definition based on our CDC recommendations. Finally, even if a PCR test was not performed for SARS-CoV-2, it is still possible for a donor to be eligible. This would be if they have no other sort of signs and symptoms or close contacts for COVID-19. There is a possibility that, again, these patients may be eligible. Now, obviously, we are potentially missing some patients here who may be asymptomatic COVID-19 carriers, as we know. But we are not at this time requiring postmortem testing. So again, at this point in time, we do not require postmortem PCR testing for SARS-CoV-2. There are multiple reasons for this, and eye banks are welcome to perform postmortem testing if they like. However, the testing is not validated on cadaveric donors. There's concerns for variable false negative rates as well as false positive rates. There's concern that you'll have persistent positivity of the PCR testing even after recovery from a COVID-19. And again, at the end of the day, we still don't know that these respiratory viruses are transmitted by corneal donation. However, if testing is performed either by the eye bank or by other donor agencies, organ banks or tissue banks, then all of that testing must be received before a donor can be released for transplantation. The hope, however, is that with increased testing that's occurring in our hospital and outpatient settings, that we are able to screen our donors a little bit better. And again, while a negative PCR isn't necessary to release certain tissue, it may be necessary in some instances. And this is where our medical directors, so our medical directors are all corneal trained surgeons who are involved with the eye bank. Our medical directors have really been essential during this pandemic to help determine donor eligibility without the need for universal testing. Other things that we should consider that sort of help give us confidence about the safety of the donor tissue include the fact that the medical standards already excludes any ocular inflammatory conditions, right? So if a patient or if a donor has a known conjunctivitis, scleritis, keratitis, iritis, whatever, and it's active, these are a rule out for transplantation, a rule out for donation. And so hopefully, if the vast majority of patients who have SARS-CoV-2 detectable in the conjunctiva or in the ocular tissue, if they have ocular symptoms, then they would already be ruled out. Finally, the recovery process that we use does require a povidone iodine contact time to all of the ocular surface. And we actually do a two rinse cycle of povidone iodine. And what we do know is that povidone iodine does help with virucidal activity against coronaviruses SARS and MERS in vitro. And so hopefully our current requirement for this double exposure to povidone iodine will help inactivate any sort of microbial contamination of the ocular surface. Again, we don't know that for sure. We don't know that with any certainty, and we don't know if the SARS-CoV-2 is deeper into the tissue and not just on the ocular surface. But again, hopefully these things do give us a little bit more just confidence in the tissue that we're using. Finally, it goes without saying that COVID-19 has really just had a huge impact on eye banking and the donor pool. And this was sort of the essence of our of the editorial that we wrote. Because of all of the unknowns, we have really erred on the side of caution. And as a result, there has been an impact on donor corneal availability during the pandemic. This is data from the most recent EBA iBank statistical report. It was just released a couple weeks ago with numbers from 2020. And what we see here, this is the number of corneas that were recovered for transplant in the US. That's on your left-hand side. And on the right-hand side is the number of US corneas that were actually transplanted. But what we see here is that in March and April, there was virtually just no corneal transplantation being performed except for emergencies. And this is when the shutdown in the US really started in full force. Domestically in the US, things began to open back up in May and June. And at this point, many eye banks have been able to recover an average of 80 to 85% of their pre-COVID volume, particularly for domestic transplantation. We are able to meet the needs of our domestic surgeons. However, what you can see here is that international surgery and tissue that's being exported for international surgeries and research continues to lag significantly. The usage of keratoplasty tissue in the US has decreased by about 14.5% since the COVID-19 pandemic in 2020, even though it had been relatively flat for about 10 years prior to that. Tissue exported abroad last year decreased by about 43% year over year, so from 2019 to 2020. However, it still consisted of about a third of the corneal tissue that were recovered by US eye banks. A third of them were exported internationally, about 16,000 tissues. But the truth is that this decrease in international donor corneal tissue export is going to strain an already strained global supply. In 2012 and 2013, Gain et al. Surveyed 157 countries, which represented 95% of the world's population. And what they found was at that time, 12.7 million people were awaiting corneal transplantation. And that's just a huge shortfall in what's needed. So for every one cornea that was available, 70 were actually needed. This map shows the supply and demand for corneal tissue around the world. The blue, including the US and Sri Lanka, are places in which tissue is exported to other countries. The red are countries in which there is no internal donation process, where they aren't able to really build their own donor pool. And you can see everything sort of in between. And so this is this is the end goal, right? This is what we need to try and see for all of us. We want to see sort of green across the globe in order to really meet the needs of all of our patients. And so, there are many challenges, I think, for international eye banks. And I don't have the solution, unfortunately, for a lot of this. But, as you know, there are no international medical standards for eye banking. And the challenges across the world include things like lack of funding or infrastructure, difficult legal frameworks for donations. It's not necessarily a high priority for health authorities. Difficulty with cooperation between different regions within a country or within a continent, and even cultural barriers to donation. All of these are the challenges that need to be overcome in order for us to see a world that is, again, self-sufficient in terms of fulfilling this vision of restoration of sight. So, final thoughts. I hope what you can take away over the last 45 minutes or so that that I've been talking is that the EBA is really committed to providing a large network of accessible and safe corneal tissue for surgeons and patients. Adverse reactions are actually extremely rare. And throughout this COVID pandemic, we've worked really hard to maintain the safety of our donor pool, trying to balance the needs of surgeons and recipients with, again, the safety of the tissue. Ultimately, at this point in time, we really just need more research to understand the true risk of COVID transmission via corneal transplantation. Global alliances and cooperation, I believe, are essential in addressing the need for corneal transplantation and corneal blindness worldwide. And the EBA is committed to this. This is one of our goals, and I'm on the board of directors of the EBA, and that is one of our goals, is to really be an organization that's able to help facilitate the needs of other countries. And one of the things that I always emphasize to surgeons in the US is that we can't be picky about our corneal tissue, right? We can't treat corneal tissue the way we treat an intraocular lens, where it's always there, it's always available, we can just kind of pick it off the shelf. And especially now in the midst of this pandemic, where tissue numbers in general are lower than they usually are, now is really not the time for surgeons to insist on certain criteria for their tissue beyond what is necessary. And then finally, it's always a reminder for me that corneal transplantation and a corneal donor tissue is truly a gift from a human being, from somebody who was generous enough to give us really this ultimate gift. I want to thank you all for your time, for listening over this past 45 minutes or so in the afternoon. And I'm happy to answer any questions that you guys may have. I see there are maybe a few things in the chat box here, so.
Thank you, Dr. Lee. I'll open the floor for the questions, and I have got two of them already. So I'll start with the first one. In terms of regulations, what was the deal breaker to advocate for donation in US? Was it a federal law or a state law?
For donation?
Yes.
We've had, I think with donation, there's so many advocacy groups in the US that have pushed for changes in laws, right? And so again, for us, that the biggest factor in changing the culture of donation in the United States was actually it's a federal requirement that every single hospital death is reported to a donor organization. And in order for a hospital to obtain funding from the government, they have to meet those requirements. And so they have to prove to the regulatory bodies that they have a relationship with a donor organization to whom they are reporting every single death. And so that was a big push, I think, from donor agencies to make that a regulation in order to increase our donor pool, right? But again, a lot of it is just advocacy on the part of our donor agencies to really make donation something that um, is that something that makes sense in our sort of cultural norms.
And the second question regarding the duration of preservation. Um, does that apply for lamellar keratoplasty if we change the optisol?
Yeah, it's still,
Yeah.
it's still a 14-day. I don't know of anybody that is using tissue beyond 14 days. It is true that we are changing the optisol tissue, but I think even though the optisol might be good for, the expiration date on the optisol might be good for another 14 days or something like that, I think the donor tissue, we still keep it within a 14-day criteria. And if you look at, the CPTS study, that was the corneal preservation time study that was performed a few years ago here in the US. What they found is that that tissue is really very, very good. There's very little difference between a tissue that's 1 day old and a tissue that's about 11 days old. And then there is a little bit of difference between 11 and 14 days compared to the earlier tissue. So I would say in the US, everything is done within 14 days.
And another question regarding healing. Has the donated cornea ever implicated in the healing process? I mean, in a perfectly healthy patient, normal surgical technique, was there issues ever with the corneas? We've previously at Kekish, we had few patients that had delayed healing despite that they were very healthy, had a healthy ocular surface.
Yeah, you know what happens, and this is part of why we have these adverse reactions, is those are the kinds of patients that we want to hear about. And so, for instance, these are the patients that we would consider to be a primary graft failure, for instance, where within the first 2 months they never completely clear, and it's not because of the recipient, and it doesn't seem to be because of the donor, not based on any of our routine screening, but it is possible that that donor tissue is not as healthy as we would have wanted it to be. So again, it's not very common, but that is an adverse reaction that we would want to know about. And usually what happens is in cases like that, so for instance, if I have a donor where I'm, a situation, a surgical case where I am convinced that there was nothing that I did during surgery to increase the risk of failure, and there was nothing about my patient, my recipient, that specifically would increase the risk of failure, and yet the cornea never cleared, never got better, never did what it was supposed to do. That is a situation in which I would report that case to my eye bank. And what the eye bank does is they will do an investigation. So they'll look back at the donor records. They'll look and see if anything was missed. They'll look and see if there was any abnormalities in the processing of the tissue. And then they'll also look at the mate tissue. So they'll look at the pair and they'll see how the other eye did and whether or not that cornea was successful or if that cornea also failed. And then based on that, it gets put into a category of, possible, probable, definitely related to the corneal tissue, um, whatever the complication was, whatever the outcome was. And then that gets reported to the EBAA. And so if an eye bank starts reporting a lot of primary graft failures, for instance, that's a trigger for the eye bank, the EBAA to do an investigation and to potentially look a little bit more carefully at a particular eye bank and its processes to see if there's something going on within that organization.
And another question related to the death to preservation, the 12
Mhm.
hours versus 24 hours. I know that the
Mm.
EPA is different from the studies. So what's your opinion about this?
So the death to preservation time, um, there's not a lot of consensus actually. This is something that my eye bank has talked extensively about. And we used to have a 15-hour death to preservation requirement. And then after 15 hours, from like 15 to 18 hours, those tissues could be utilized if I approved it. Basically, I'd look at the tissue and decide whether or not it was okay for transplantation. And the reality is it never really made any difference. I think there's not a consistency amongst eye banks in the United States from a death to preservation time. So after a patient's died, I would say somewhere between 12 to 24 hours is where people tend to land. And I don't know that we have good data to show that 12 hours is really better than 24 hours. For my personal eye bank, we try and keep it below 18 hours, but we don't really have data for it.
And another question about the Life 4C versus Optisol.
Hmm.
About it.
I personally don't have a preference. I think they're both great. I don't know how much the insulin that's added to the Life 4C makes a huge difference. Personally, I haven't noticed it. I use whatever is given to me. Yeah.
Yeah, an interesting question that I got about donation. In US, can the family change the wishes of the donor from consenting to non-consenting?
So technically, if a donor of a person has already consented, that's enough for an eye bank to utilize that tissue. It's enough. That being said, part of the screening process for that tissue is that you have to talk to someone who knows the patient, right? You have to get a good history, a good social history, a good medical history. And if you don't have their cooperation, you really can't proceed with utilizing that donor tissue. And so I would say in the US, even though first person authorization, so if I sign my tissue away for corneal donation, that's enough. I would say most eye banks still seek authorization from the next of kin or from their relatives, because it's the right thing to do, right? It would be hard if a family were to decline donation for you to really over supersede their wishes. They can do things like educate the family about the donor's wishes, right? So that's one thing that they do utilize a lot, that your family member has expressed that they want to be a donor. And often that's enough to get the family on board as well. But like I said, it's very unusual for us to go against what the family wants, but we do utilize what the donor wants to help influence the family.
And final question is about tumors as a contraindication. What's your opinion about metastatic tumors from the body and the head and neck tumors?
So in general, again, when we created, the issue with melanoma was obviously a real issue. And that's what triggered all of our looking a little bit further at metastatic tumors. And again, the big one is melanoma, where these cells can be anywhere, everywhere, and pop up at any point, even 20 years later, right? And so metastatic melanoma is an automatic rule out for us. As for solid tumors, we had a long discussion with Carol Shields when we were creating these guidelines. And the feeling was really that because the cornea is avascular, that the risk of transplantation of malignant cells through the cornea itself was relatively low. That being said, I believe that use of scleral tissue and use of conjunctival tissue for KLAL in the context of someone who has metastatic solid tumor is contraindicated, just because we felt that with the vascularization associated with both the conjunctiva and sort of the scleral tissue, all of the vascularization around it, that would be much more high risk. But for the cornea itself, again, just the fact that it's avascular seems to decrease our concern about that.
Thank you so much, Dr. Lee. We've enjoyed your presentation and we hope to see you next year in another presentation.
I would love that. I actually see one more. There was another question addressed to me via my chat messages about, I'm just going to answer this real quick, about is there any specific immunocompatibility tests that can predict the chance of tissue rejection? And the answer is no. We don't. The cornea donor study really showed that, at least based on the study which was conducted in the US, we did not find that ABO compatibility impacted the outcome of corneal transplantation. And so, no, I don't think anybody routinely does that in terms of immunocompatibility. But I believe that some of the tests out of Europe seem to suggest that there may be some impact on cornea survival. And so I would say that there are some people who, after multiple failed corneal transplantations, may ask to have compatibility testing performed. But you have to realize that in order to get that done, it requires a huge amount of effort in order to try and accomplish that, to meet that need. Okay,
Thank you.
that's it.
Thank you, Doctor.
All right, thank you all so much for having me. It's been a pleasure. Enjoy the rest of your day.